The title of my project was Patients and Caregivers' Preferences for Services and Supports Near the End of Life, Evidence from a Discrete Trace Experiment. So we went with this research because we wanted to ensure that care was delivered in a way that patients and caregivers actually wanted, to ensure that services met their needs and ultimately could to cater to their most important preferences. So we used a discrete trace experiment, which is a tool that's used in surveys to find out about people's priorities or the trade-offs they make between different characteristics of care or services. In all, we interviewed 69 caregivers and 75 patients across 3 regions of Ireland. So the key findings from the research were that it was really important for both patients and caregivers to know whom to contact. That person didn't always need to have the answers to their queries. They just needed to know who to contact and to not feel lost in the system. So what was interesting about the regional differences is that we found that people's understandings or perceptions of palliative care ultimately determined where they wanted to be cared for. So if people believed that hospice would hasten death or was only for end-of-life care, they'd be inclined to not want to receive care there and to stay at a hospital. When we look at regions who have well-developed hospice services, people expected and anticipated that they would be cared for. Actually, it was the only option for them. Patients and caregivers often have very different preferences, and it's very different things that lead to a good experience. So we also found some really interesting results around decision-making, and particularly how age influences participation in decision-making. So for caregivers, there was an overwhelming preference for patients to make decisions autonomously without the input of doctors or other people in that decision-making process. However, for patients, the process or the nature of decision-making wasn't that important. It actually didn't really influence their decisions in the experiment, at least. But what we did find ultimately in some further analysis was that there was a quite interesting age effect. So younger patients were quite happy to have decisions made alongside with doctors or autonomously, whereas older patients weren't as concerned with the nature of decision-making. They didn't really let it influence their choices. So what I think is one of the most important findings from this research is the value and importance of process in determining people's satisfaction. So quite often when we evaluate healthcare interventions, we look at a single endpoint as determining whether or not something turned out right. What this research has shown is that quite often it's the journey to that endpoint that actually matters a lot more. We need to be careful that we look to measure that and to understand the circumstances that actually contribute to something that is considered a good process or a good experience for families and for patients.
Hello, my name is Mas Mohammed. I'm a psychiatrist with the Cognitive Impairment Research Group in the University of Limerick. I'm currently working on a project called the Milford BrainSafe Project, along with a group of multidisciplinary researchers. This project is based in Milford Care Centre in Limerick, and the wider aim of this study is to examine the relationships between symptoms common to patients in an inpatient palliative care setting. So symptoms such as cognitive problems or memory problems, depressive symptoms, pain and fatigue. My research focuses specifically on identifying the best ways to assess for depression. Depression is very common in patients with terminal illness. Around 1 in 6 of palliative care patients have major depression, and the rates tend to be a lot higher for non-cancer diagnoses such as MS and end-stage heart failure. Unfortunately, depression often goes undiagnosed or untreated for a number of reasons. Additionally, patients with terminal illnesses such as advanced cancer often share symptoms common to depression. For example, they may have significant weight loss, significant fatigue or tiredness, and poor concentration, all key symptoms used to diagnose depression. So here's what we found. When we compared various assessment tools in 142 palliative care inpatients against clinical diagnosis made by an experienced psychiatrist, One tool in particular performed especially well. This tool is the Cornell Scale for Depression in Dementia, or the CSDD for short. Unfortunately, the CSDD takes quite a bit of time to complete or to assess properly because it has 19 items and the clinician has to rate the patient for each of these 19 items. So as a follow-on, what we did was we looked at these 19 items and using the data that we have, managed to narrow down the 19 to 5 items that identified patients with major depression with comparable accuracy as the 19 items. This is a really important finding because we now have a brief and simple to use tool to assess for depression that can be used by palliative care physicians who are often under severe time constraints and who may not have extensive psychiatric training in order to identify palliative care patients with major depression. This result raises a few other questions. For one, how well does this abbreviated scale perform in other palliative care settings such as daycare patients or outpatients? Additionally, will the abbreviated CSDD perform as accurately in other elderly patient populations such as nursing homes or on a general medical ward?
Cancer cachexia is a particular type of weight loss where there is progressive and involuntary loss of lean muscle mass. Refractory cachexia refers to the stage where reversal of the weight loss seems no longer possible. At present, there's no recognised treatment for refractory cachexia, but we know from previous research that refractory cachexia can have a massive impact on both patients and their family members, and it can impact on them biologically, psychologically and socially. We know from previous research that cancer cachexia is under-recognised and underdiagnosed. Patients and family members have themselves told us that when they reported the signs and symptoms of cancer cachexia, that they were met with silence by healthcare professionals. And healthcare professionals have also previously told us that they didn't know how to best manage refractory cancer cachexia. We set out to design an intervention for patients with advanced cancer who have refractory cachexia and their family caregivers. And the aim of this intervention was to improve quality of life for both patients and their family members. We designed the DVD intervention in collaboration with our clinical colleagues and also with past carers who had cared for someone who had cachexia. And we also took on board previous research within this area. The DVD intervention started with a brief introduction to what cachexia is in advanced cancer patients, and then was divided into two particular sections, one for patients and the second section for carers. We asked both our clinical colleagues and also the previous carers to help us design the content of the DVD. We also asked them to give us feedback once the DVD was developed, and from this feedback they were able to tell us that they felt the DVD was very useful to help explain cancer cachexia and what it was and what its impacts were. In particular, past carers felt it would have been really useful for them to have this DVD whenever they were caring for their loved one with cachexia. And healthcare professionals told us that they felt the DVD would be really useful for them as it helped raise awareness of what cachexia actually is. Due to the huge impact that cancer cachexia has on not only patients but also their family members, this research is really important, as we would hope that this intervention will help us educate healthcare professionals about how to recognise, how to respond to and how to manage cancer cachexia. In future research, we would like to use this DVD intervention to assess its impact on cancer cachexia management in clinical practice. We would hope that if it positively influences clinical practice, that this in turn would help patients and their family members cope with the impact of cancer cachexia. We have also worked with senior cancer colleagues in both the Mayo Clinic in America and also St Vincent's Hospital in Australia, and we have collected data from healthcare professionals working within these areas on how cachexia is managed. From this work, we would hope to see if the DVD intervention that we have developed as part of this study would be useful internationally to improve the management of refractory cancer cachexia.
Our research looked at a common problem in health services research, and that is the challenge of ensuring that research on practices, on interventions, moves from research into practice, reaching the people who are working in health settings, people who are developing policy for health settings. In conducting our study, we wanted to learn lessons from the existing published papers. So we gathered together a comprehensive review of information on this issue of knowledge transfer and exchange. And we analysed it to identify what were the core elements of knowledge transfer. And we identified 6 key components. We gathered these components into a model that we call MTREC. So MTREC's 6 components are, firstly, the message. What is the information that you want to transfer? And how can you most effectively ensure that that's relevant to the people hearing it? The second component is the stakeholders, the people who need to hear this message. The third component is the process by which you share that information. For good communication, you have to use social media and other platforms to speak to people in a way that they can engage with. MTREC also recognises that this process happens in a context that is both about the organisations where researchers and practitioners are working, but also the social, cultural and economic context where the research has been done. So, for example, research in palliative care relates to people's attitudes towards death and dying. And when researchers are trying to communicate these messages, they have to keep in mind that those attitudes could affect how people hear the messages from their research. So having developed this model, the final component of which is evaluation, can we make sure that our communication is working? We wanted to find out how relevant it was to palliative care specifically. And to do this, we conducted a small series of case studies whereby researchers were asked to use the model to inform their work. One example of a project is Kindle. The Kindle project, run by the Institute, looks at maximising the learning from a range of research projects that have important messages for service users, their families, practitioners and policymakers. Having identified this small group of researchers who were using the model, we were able to gather their feedback on how they found the process. And they had a number of key messages for us. The first was that the model was easy to use and was relevant to palliative care. The second message was that they found that the model was trustworthy and was credible. It was doing the job that it was designed to do. And finally, they found that it positively contributed to their research, suggesting that it improved their engagement with a diverse range of activities such as social media, talking to the public and engaging with practitioners, which many of the projects did. So in moving this research forward, there needs to be more research to see how well this works for different researchers working in different contexts. But we're also very keen for this to be a real living resource for researchers. And so we're working with the Institute to develop workshops and other resources to build the capacity of researchers in palliative care to effectively share the messages from their research.